Hi everyone, it's Rob Arnfield speaking to you from Western University again. Going to talk to you today about lung and pleural ultrasound. We've previously spoken to you about lung acquisition techniques and our protocol or sequence we use here at Western. If you haven't seen that, I would suggest watching that first. The biggest rub with lung ultrasound for most people is the fact that it's non-anatomic. When you look at the rest of point of care ultrasound, you look at the anatomic images like this fast exam with fluid around the kidney, the liver. You can show that to patients' families, to the janitors, to the nurses, to the hospital CEO, and everyone understands intuitively what they're looking at or can get behind it a little bit. But when you show somebody this and try and tell them that it represents pulmonary edema or ARDS, it's a bit more of a leap of faith because it's artifact driven. As you increase your proficiency and your use of lung ultrasound, however, these artifacts become a new language, and your fluency in interpreting them and acting on them becomes greatly simplified. To give you an example, of course, we all one stage had to learn what these various electrical artifacts meant with respect to EKG interpretation. For obviously this small peak here looks nothing like atrial contraction, but now when you see that on a EKG trace, you associate it with that anatomic event. Lung ultrasound is no different, and as you increase your exposure, you will begin to love it more and more, I assure you. With respect to its diagnostic performance, here's some very important references that we can use to derive the diagnostic performance in a variety of conditions that can cause acute respiratory failure. And you can see from the table on the left that they perform very, very well. So today we're going to emphasize the 5 ultrasound signatures that you can see in the thorax when you put a probe on a patient who has acute respiratory failure. Any given patient will have any number of these different signatures present in their chest, and integrating these into one representative respiratory diagnosis can sometimes pose a challenge, or is certainly something that you will get better at over time. But at first, the most basic level is you must recognize the signature of the artifacts that you're demonstrating. So let's start with sliding lung. Sliding lung is the most classic of lung ultrasound artifacts and is the one that everybody should know. Its value in particular relates to excluding pneumothorax, which it does with 100% certainty at the site of your transducer. So with a couple quick points on the chest, you can take a life-altering and life-threatening pneumothorax off the table in a matter of seconds. To understand lung sliding, let's take you through a couple schematics. First, the sagittal projection across the ribs is going to show you this type of picture. And in this screencast, we're going to show you a lot of vascular or linear array images just because they're more vivid, are better for teaching purposes. But in practicality, as I spoke in the last screencast, we tend to use a phased array probe most often. So here's a typical image of lung sliding with the chest wall, rib shadows on either side of the ultrasound screen, a bright hyperechoic line, which shows some degree of dynamic movement or shimmering or sliding, call it what you like, but there's movement there, which tells you that the lung is up. And deep to the pleural line is really a sense of nothingness that's cast by the air, as air doesn't provide any meaningful information to ultrasound, as it causes immense scatter to the ultrasound beams. So this is a classic picture of a lung sliding image. Now let's dissect why you see lung sliding and how that is formed. So when you place the ultrasound transducer across the chest wall, you're really sending the ultrasound beams through 2 layers of pleura. The parietal pleura, shown here as blue, and the visceral pleura, that is red. And during tidal respiration, these pleura move relative to one another. Of course, the ultrasound beam typically is not powerful enough to distinguish both layers of pleura, and instead visualizes these layers as one single line known as the pleural line. Now this line is a hyperechoic line, and instead of appreciating the 2 layers therefore moving relative to one another, all you can appreciate is the actual movement of that single bright hyperechoic pleural line. Now the animations are crude, but ultimately you can get the sense that now when I superimpose the actual ultrasound image, this bright white line is the pleura, and it's the artifact movement that you're seeing there is indeed related to tidal respiration between those 2 layers. And of course, if those 2 layers are articulating with each other, there cannot be a pneumothorax that separates them. Now in the case of pneumothorax, let's consider what we may see. So we know that again we're going to have our 2 layers of pleura, the parietal and visceral pleura. but between them is going to be interposed interpleural air. And so in this case, the ultrasound beam is going to be able to see the parietal pleura, but deep to the parietal pleura, the air will obscure the visualization of anything else, including the visceral pleura, which is beneath that interpleural air. So while there may be movement of that visceral pleura if there's some tidal respiration into the lung, this is inapparent to the ultrasound, which can only see a static pleural line from the parietal pleura, which has no relationship in this case with the visceral pleura. So you can imagine that in this case, you see a quiet, very still, non-dynamic pleural line framed again by the rib shadows, which are seen here, and there's absolutely no movement. There's a little bit of movement of the operator with the probe and efforts and breathing from the chest wall, but the line itself is static. Now, the absence of lung sliding is a little more complicated. As I've told you, the presence of lung sliding can rule out pneumothorax. Its absence does not rule in pneumothorax, and there's a variety of conditions that may lead to the abolition of lung sliding, and they're listed here. I think, therefore, as I've emphasized, the main value in lung sliding is the rule out. Occasionally you can rule in, and we'll get to that in a minute, but the other, in addition to pleurodesis, we also have people who have large bullae in their apices, or COPD, who often lose lung sliding. And the people who are apneic and who have main stem intubation, their lungs doesn't slide because there's just no delivery of tidal volume to that area of lung. But we'll show you in a second another sign that can help you distinguish these people from those who have truly absent lung sliding. And that's this one here. It's called the lung pulse. So the lung is up because we say this is a main stem intubation. We see a rib shadow, and here we can see there is movement of the pleural line, and unless this patient's breathing around 90 breaths a minute, you can actually see that the movement of this line is in cadence and with the cardiac activity. And this movement is caused by the physical reverberations of the heart and the way it jostles the lung around, which includes the two layers of pleura, creating a lung pulse. So to check this out, just hold your breath next time, put the probe on your own chest, and watch your own lung pulse go to work. Now, the last sign related to the lung point or the lung sliding is the lung point. Now, this is something you can see if you insonate the chest right at the terminus or origin, depending how you look at it, of the pneumothorax itself. It's not always seen, but if you do see it, it's fairly specific for pneumothorax. And if you understand this sign, I would hazard to say that you understand actually the whole lung sliding artifacts that I've been describing to you up until now. So let's look at what happens here. So here you have a CT composition of a pneumothorax with the air here and the lung that's up here. So you can imagine that where this red arrow is seen, it represents the intersection of pneumothorax and no pneumothorax. You can imagine what the ultrasound findings would be here, can't we? Because we would have a lung sliding here, an absence of lung sliding here. So if you were to superimpose a crude image here, you would see that we here have a quiet lung, and here we have a sliding lung. And to show you in a bit more zoomed in version, here we have a rib shadow central to the image. We have a dynamic lung sliding here that ends though here, and this lung is quiet. So we have both pneumothorax, or a lung that's not sliding, and a lung that is sliding, all in the same image, and that is known as the lung point. So that really represents the origin of the pneumothorax. So if you can understand why you're seeing that, I think you understand lung sliding. So as I've emphasized, the power is in the rule out with lung sliding. I think portable chest x-rays that take 15 minutes to an hour, depending what institution you're in, is an unbearable period of time to wonder if somebody has a pneumothorax. Empiric needle decompression really is ineffective, we know from cadaveric studies in a lot of people, and certainly not a desirable thing to have to do empirically if you have a tool that can very quickly tell you whether or not a pneumo is present or absent. So the ability to rule it out is the power of this technique. Now let's move on to parenchymal findings, because lung sliding largely relates to the presence or absence of pneumothorax, but we also want to know whether or not the lung is diseased or not. And so we're going to be talking about two signs in succession now, one called A lines and one called B lines. Now, A lines are cast in the setting of ultrasound and air, and if the ultrasound is exposed to air and the air itself is not interrupted by things like fluid or pus or hemorrhage or lung injury, then it produces something called A-lines. And so the effect is if you see an A-line pattern in lung ultrasound, it suggests that the parenchyma itself is not diseased. And so if you can demonstrate an A-line pattern throughout a chest, you can effectively rule out parenchymal disease as the cause of respiratory failure, and therefore consider differential diagnosis that includes non-parenchymal disease, such as airways disease like COPD or asthma, pulmonary embolism, fatigue from metabolic acidosis, you name it, but it's unlikely to be things like CHF, ARDS, pneumonia, pleural effusion, other things that are causing parenchymal disease. So let's look at the A-lines themselves. Here we have an image captured with a phased array transducer. You can appreciate the pleural line up here with more of a kind of a shimmering appearance to it than sliding, which you'll find it'll take on varying appearances in different patients. And then you can appreciate that there's a horizontal kind of repetitious line that is equidistant beneath the pleural line. It's the same distance as the distance from the pleural line to the surface of the transducer. And so these lines are superimposed upon one another, and this is just a normal artifact that you see in the setting of aerated lung that is unimpeded by other disease process. So A-lines are good, and we can see them again here with a little schematic that reminds you how they're formed, that effectively the ultrasound energy bounces off the bright pleural line, bounces back off the ultrasound transducer, and this pattern repeats itself each time. Each cycle it goes through, it plants the image and the ultrasound screen of another pleural line effectively. And this is, of course, is an artifact, and the behavior of this artifact, you just have to believe me, and you just have to believe the physics. It means that the lung itself is okay. Again, this is not what lung looks like. This is an artifact cast through lung that harbors normal aerated pattern. The number of A-lines that you see here is unimportant, and really you just need to see one. If you see multiple, that's great. It can be additionally easy to interpret. And further, you must be sure to bring out the A-lines by making sure your probe is perpendicular to the pleural surface, not just the skin surface. So sometimes a little manipulation required to bring out the A-lines. And now, because I've told you A-lines mean that the lung is unhindered by fluid, for instance, it's been shown that an A-line pattern, if you see A-lines throughout the lung, correlates quite well with low left atrial pressure and can effectively rule out elevated filling pressures on the left side, which in the context of large volume resuscitation, in addition to a cardiac assessment, can give a lot of strength to a management strategy that would involve more fluids. Suggest the lungs may be dry, and a permissive approach can be taken. And that's something that Lichtenstein, the father of lung ultrasound, has called the Falls protocol, and many have used it in clinical practice. So the sibling lung signature to the A-line is, of course, the B-line, and the B-line, a vertical hyperechoic finding that extends from the pleural line itself. It moves with the pleural line, and it must extend to the bottom of the ultrasound screen. And this artifact, as we'll review in a moment, is created by fluid or thickening in their interlobular septae between the alveoli. And often this occurs before fluid accumulates in the alveolus, and often before X-ray findings even can demonstrate edema. So it's an incredibly sensitive finding for fluid or fibrosis or thickening in the alveolar interstitium. So let's have a look at some B-lines here, again acquired with a phased probe. You can see a rib shadow here and a rib shadow here, but the bright pleural line you see is casting these light rays or lung rockets or B-lines, call them what you like, but you can see they move with the pleural line, and they must go to the bottom of the ultrasound screen. So even if we increase the depth, you'd still see the B-lines shooting down all the way to the bottom of the screen. And let's review exactly how these are formed. So the ultrasound beam is cast through the alveoli here, which are shown in schematic, and there's, for instance, thickening or fluid in the interlobular septae, and the ultrasound energy, as it pulses these small molecules, they vibrate and reverberate, and they constantly send back a signal to the ultrasound beam, and the ultrasound probe rather, and the ultrasound probe will interpret this as energy emanating from this point, but a constant energy, so it will plot pixels, bright pixels, along the entire vertical length underneath those alveoli. So again, we are interpreting artifacts here that tell us anatomically what's going on or pathophysiologically what's going on, but in a way that is unfortunately cast in a non-anatomic fashion, but extremely accurate. So you can see here again a nice example of B-lines. What do you make of B-lines? Well, generalized B-line pattern suggests the same thing as an interstitial syndrome on CAT scan, or what they often call a ground glass architecture on CAT scan. And the differential is similar to what you would make of for an X-ray that looks like this if you had diffuse B-lines, so things like CHF or ARDS. If you had unilateral B-lines, you might consider things like pneumonia in its early phases, or again a bilateral picture with interstitial lung disease as well. Most commonly we're interested in the CHF or lung injury patterns for B-lines for rapid diagnosis of an alveolar cause of respiratory failure. So there's obviously a spectrum of the burden of B-lines you can find in any ultrasound window, and a single B-line we all harbor every once in a while. We all kind of accumulate a bit of fluid, but as soon as you exceed 2 and you get into 3 or more B-lines in an ultrasound field of view, then you start thinking it's pathological. And so here we see kind of a pathological number, and here we see very almost coalescing B-lines in this rain shower kind of appearance on the lungs, which is much more severe. And so how I use B-lines, I use it often helpful for an immediate diagnosis of pulmonary edema, far more reliable I find than a stethoscope. Also to help with diuresis decisions in subacute patients in the ICU who often have gross anasarca, but difficult to determine if their lungs are still harboring volume inappropriately. And as I said, it's useful in shock with respect to an A-line versus B-line profile. If you have a shocked patient who's A-line predominant, you give them volume. If you're starting to see B-lines, you can suggest that you're probably reaching the end of your volume curve potentially, or have features of elevated left atrial pressure, and you maybe need to switch agents or consider co-administering vasoactive drugs along with volume. So lots of great applications of B-lines in the critically ill and emergency patient. So again, here's a contrast side by side, nice horizontal, normal aeration pattern here with lung sliding, and here we have the vertical ray-like structures moving with the pleural line going to the bottom of the ultrasound screen with B-lines. So finally we move to some lung signatures where you actually get to see the lungs, and the good news is there's some anatomic signatures with the lungs that aren't just artifact based. So you can see lungs when they lose their air in the context of consolidation, or when they're surrounded by fluid in the context of an effusion. So here's an example of lung sign number 4, what we call a consolidation pattern. Here we have a pleural view on the left side with diaphragm, spleen. We have a solid organ density above the diaphragm here, which represents a completely collapsed left lung. Now, the etiology of consolidation is the de-aeration of that lung, whether it's complete atelectasis or if it's pneumonia that has replaced the air with fluid and pus, is a matter of clinical correlation. And there are some ultrasound signs that many will speak of that can help you distinguish between them, including dynamic air bronchograms. We're not going to get into that today. Really, just the bottom line is if you see unilateral consolidation, somebody with a fever and a white count, I'd favor pneumonia. If it's bibasilar consolidation in a patient who's been ventilated for a few days and is otherwise afebrile, I'd favor atelectasis. So you do have to correlate it clinically, but often very helpful finding in patients with otherwise undifferentiated respiratory failure, because even a degree of this much of consolidation is often occult to chest x-ray, you'll find. And the last sign, a very common sign that's very familiar to many practitioners of all specialties, is the pleural effusion sign. And again, a left upper quadrant or left pleural space view, diaphragm, spleen, black is fluid, and the lung itself is collapsed under the burden of the fluid. Now, it's important to recognize that collapsed lung under a burden of fluid is not consolidation. It's an appropriate amount of consolidation, but the primary process in this case is a pleural effusion itself, and the lung just can't get air into it under the burden of the pleural fluid. So here's another example. Again, nice picture here of spleen, diaphragm, and collapsed atelectatic lung, appropriately though, because you can see how it's encased in fluid. And to diagnose pleural effusion, you really need to see the chest wall. You need to know that you have a diaphragm. Really, you must identify the diaphragm. Not everything that's black and near the chest is an effusion. And you have to see dynamic signs. You have to see the diaphragm move or the lungs start flapping to really be sure that That's an effusion, in particular when you're looking to stick needles in it. And with respect to sticking needles in it and drainage, many people, as you start using ultrasound for the lungs, you'll find pleural effusion in virtually everybody in an ICU setting. And because of your increased sensitivity, it then raises questions inevitably about therapeutic decisions. And one tool that I find helps people, rightly or wrongly, make the decision about chest drainage or not is derived from this study here, which was able to reasonably estimate the volume of fluid in the chest using a dimension measured from the diaphragm to the base of the atelectatic lung in end expiration. And that maximum distance, when applied to a fudge factor here, that distance in millimeters multiplied by 20 would give you your volume in milliliters, is the rough estimation of how much fluid you're going to get from chest drainage. And so that's an equation and formula I tend to use, rightly or wrongly. It's a small study, but it gives you a bit of a sense of size. It doesn't apply in people who have loculated effusions, people who have complex effusions where the lung is tacked down, but does help guide chest drainage decisions. Rightly or wrongly, many people have opinions about the amount of fluid and how much is worth draining and how much isn't worth draining. Though we still don't really have the answer to that question, it does help with decision making. So in this case, we can see about a 50 millimeter effusion by that measurement multiplied by 20 would give us about 1,000 cc's or 1 liter. Of course, you can see other variations on this lung signature, including a complex effusion. Here we see the diaphragm, we see a bunch of debris and fibrin intermixed with the black fluid, and that's suggestive of a complex effusion, which could be a retained pneumothorax or an empyema or any number of things, and carries a slight variation on the lung signature. If you want to put it all together, there's a great study that's a fabulous review of Lichtenstein's work done by him, applied at the bedside, blinded to those with respiratory failure, and shows how he's able to use these lung signatures that you've just heard me drone on about in real-time fashion, and to use them to very accurately pigeonhole patients who are on ventilators into the actual cause of their respiratory failure, just using these lung signatures. So it's a great study, and I would encourage you to check it out. So the summary of the ultrasound signs: lung sliding, absence lung point. A lines represent normal parenchymal finding of air. B lines, vertical projections related to edema or ARDS, sometimes pneumonia. Consolidation, sometimes also called hepatization. It can be pneumonia versus atelectasis. And then pleural effusion, sometimes the easiest to spot but the hardest to know what to do with, and that measurement strategy I mentioned may help. Ultimately, I hope you'll agree that though non-anatomic and artifact driven, as you gain fluency and you teach others how to be fluent in this technique, that lung ultrasound is ready for prime time. You'll use it in all your patients with respiratory failure. You'll be much less reliant on chest x-ray, and you'll have a superior diagnostic performance at the bedside to help your critically ill patients. That's it for now. Thanks for listening, and happy scanning. You can find us online at westernsono.ca.